Example of the kind of research I do. It's called translational research. Does what you do in the lab actually work in real life? So I am from the UC Davis Betty Irene Moore School of Nursing. I'm going to talk about graduate and professional education today. So this is where UC Davis is. We're in both Davis and Sacramento. So the main campus is in Davis. That's where most of the core departments sit. It's where all our undergraduate and graduate education is. And then we have the Sacramento campus, which is where the health sciences are. And so that's the School of Nursing, the School of Medicine, the Medical Center, some public health, and a smattering of other things. So I'm at the Sacramento campus. But what's on the map is what we consider sort of our catchment area. This is what we serve as a health system. So we're the furthest north of the UC campuses, and we serve most of the Central Valley and the far north part of the state. So most of that is rural. So this becomes important in an example that I'm going to give you a little bit later. So we have some wonderful resources. The Center for Health and Technology and the Center for Virtual Care, which were actually developed with the leadership of Dr. Tom Nesbitt, who's here, who's really been a pioneer in telehealth and telemedicine in the world and definitely in the state of California. So these are some examples. So telehealth is where we're actually providing consultations and services to people across the state and across the world where they don't have access to services like specialists. So we have 28 different specialties that are accessed via the telemedicine system. They all sit in the Sacramento campus. We have over 100 sites that are connected to the Sacramento site so that they can get these sort of specialty consultations. And you need a lot of infrastructure to do that because you're running actual services via the telemedicine system. So we have all that infrastructure. And then we have the Center for Virtual Care, which is a set of resources that are not just telemedicine, where you have live people talking to each other and seeing patients via the telemedicine system, but you're able to simulate now different kinds of healthcare services, whether they are exams, consultations, actual procedures, the entire gamut of the kind of clinical services that you might provide. That's what we use to do the clinical education. So you can see along the bottom a couple examples of both lo-fi and hi-fi mannequins that react as close as possible to the way humans actually react. And so medical students and nursing students can be trained on these mannequins to do procedures and exams, to do entire surgeries, or to do interventions. And so that's really about clinical education. But we're a medical school, we're a nursing school, we're an informatics school, and we are a public health school. So we're not just training clinicians. We're also training researchers and veterinarians, and we're training people who are going to be informaticists. So we have a broad range of things that we're trying to do. So this helps us with clinical research. It helps us with clinical training, but it also helps with these other aspects. So because we have people who are going to be researchers, this helps us to actually train people to do translational research. So if you do basic research, if you do studies that say that a particular procedure might actually be better than another procedure, or a medication might be better than the existing drugs that are available. You do these randomized clinical trials, which are considered the gold standard. Everything's tightly controlled. You have protocols. Everyone does exactly the same thing, delivered in exactly the same way. And then you get out into the real world, and nobody does everything exactly the same way. You have different environments. You have different kinds of people delivering that intervention. You have different patients who live in different places. So if you really want to know, does that work in the real-life environment, you have to do a pragmatic trial. Pragmatic trial is looking at things that were demonstrated efficacy in clinical trials, and now you try to put them in the environment and see if they still work and if you still get the benefit. Now, when you get pragmatic, you got to think about implementation. Just the way that you look at implementation for technologies, you have to look at implementation for interventions. So how do you know that the implementation of that intervention or that procedure or that treatment is really going to work in the world? Simulation. So we use these kinds of resources that we have to simulate the intervention before we go out to a pragmatic trial. So an example of that is one of our the seed grant that we have that Bjorn and I are co-investigators on, where we're developing a mobile and social system for optimizing very complex chronic multi-comorbid care coordination. So we're developing the system, but how do we know how it will actually work for people without going into people's homes, without going into the clinic environment where we're going to disrupt the actual services that are being provided? So part of our testing of the system that we're developing will actually be in our simulation suites. So we can bring a small number of advisors that represent patients and caregivers and doctors and nurses and care coordinators into a clinic, a simulated clinic setting, a simulated hospital setting, and a simulated home setting, and allow them to interact with the technology to look at those implementation aspects before we try to go out into the real world. This is also important when you look at the ways that our healthcare system is sort of changing to try and be more cost-effective, to be more centered around patients and the family and their needs so that we can improve health. There are some models like patient-centered medical homes, which are in the primary care setting, where physician practices and clinics are really trying to organize all of the services around those individuals and their needs and the ways that they are actually living in the world. So bringing health out to the home instead of organizing it just for the clinical setting. Patient-centered medical homes, there are many other models like that where you really need to know how do you organize these services. So you can use simulation to do things like that. So there's also something called the flipped clinic, which is where people are experimenting with what are the best ways to organize things so that they're centered on the patients, what are the technologies that you need to have in place, what are the interactions that you need to have if you're going to bring the clinical system and the services to the person where they're actually living. Similarly, in the education, we're trying to do flipped classroom, which is, you've heard a lot of the examples actually of what flipped classrooms are. For us, we're doing flipped classroom in real time and in-person education. So I'm part of the UC Davis Betty Irene Moore School of Nursing. So we actually launched with our first class in 2010. With a $100 million grant from Gordon and Betty Moore. So we had the luxury of some resources to try some new things. And one of the new things that is being built right now is a brand new Betty Irene Moore Hall. So we have an opportunity to build our learning spaces on campus to do the kinds of simulation, the kinds of interaction, the kinds of active learning that we really want to do. And so this is just an example of some of the spaces that we will be building that really allow for the learning to be the active component when you're in person, whereas the didactic components that we usually have in a lecture hall can be done online. So I bring this up because this also allows us to get back into the community. So when you have all these resources, you can actually do education for clinical professionals and other healthcare workers that don't require you to bring them all into your campus to get that kind of training. So one example is a project that we're doing in the Central Valley. I showed you the map. We have a large swath of California that is agricultural and rural, where we have an entire healthcare workforce that has very little access to continuing education and to new kinds of roles that they might play. So we're working with community health centers in the Central Valley that serve very low income and publicly insured patients to train their medical assistants to become health workers, to become health coaches. So this is a whole set of skills and knowledge that they don't have now, but that will let them to better manage people who have chronic conditions like diabetes and hypertension. So we started with in-person training, but that required 80 hours of in-person on-site training, and we trained 22 people. So you can't really scale that kind of model. And so now what we're doing is leveraging all the resources that I've shown you, both online education with a hybrid model, to make sure that the training they've received actually works when they go back to their health centers and try to apply those skills with the patients and with the care teams that they work on. And so we're working on that project right now. So I think that we get this opportunity to try a lot of things and then to see whether they actually work in practice. And that's what I'm really excited about.